On behalf of the American Heart Association, I would like to welcome you to today's webinar, Does Your Hospital Target Aortic Stenosis? Learn how to get involved. I'm Kaylee Sada, Program Consultant for Target Aortic Stenosis at the American Heart Association. Edwards Life Sciences is our national sponsor for the American Heart Association's Target Aortic Stenosis initiative. I'd like to begin by going over a few items so you know how to participate in today's event. If you'd like a copy of the presentation, you can download a PDF from the handout section of your attendee control panel. If you experience technical difficulties, most user issues can be resolved by refreshing your browser, changing browsers, or making sure to allow pop-ups. If that does not work, please review the system requirements or contact the GoToWebinar customer service team by using the system requirements link found in your confirmation email. At the conclusion of today's presentation, you'll receive a link to access today's recording and an invitation to complete our feedback survey. We welcome you to submit text questions for our presenters at any time in the questions pane of the control panel. We will collect your questions and address them at the end of our presentation as time allows. There is a brief look at the agenda on our next slide here, please. And as we begin, it is my pleasure to introduce our first presenter this afternoon, Dr. Brian Lindman. Dr. Lindman is the Medical Director of the Structural Heart and Valve Center and an Associate Professor of Medicine at Vanderbilt University Medical Center in Nashville, Tennessee, and spends most of his time on clinical translational research centered around aortic stenosis. He's a member of the Science Advisory Group of the Aortic Stenosis Initiative, and Vanderbilt is one of the 15 centers participating in the initiative. Dr. Lindman, I'll turn it over to you.
All right, thanks, Kaylee. Can you hear me okay? It's my pleasure to present a brief overview of the HA Target AS initiative. As Kaylee mentioned, we've been one of the 15 initial sites that were part of the Learning Collaborative from Phase 1, which I'll unpack a little bit in the slides forthcoming. But it's my role today to give some context for why are we even doing this initiative. This is a paper that was published in JACC about a year ago from the NGH Brigham system, in which they looked at over 10,000 patients in their system between 2000 and 2017. And they were trying to identify patients who had a Class 1 or a Class 2A indication for valve replacement for severe aortic stenosis. And as you can see on the next slide, they identified a large number of patients who had a Class 1 indication or a Class 2A probable indication for AVR. These are patients with symptomatic severe aortic stenosis, some with high gradients, some with low gradients. And you can see on the left-hand side that those who had a Class 1 indication for AVR, that is high gradient normal EF patients with symptoms, 30% of those patients were not treated with AVR. And you can see that the mortality cost of not performing valve replacement was substantial over a 2-year time period. In the bottom left, you see a striking data showing that patients with high gradient low EF aortic stenosis, regardless of symptoms, had a marked difference in 2-year mortality, 84% versus 28%, based on the performance versus non-performance of aortic valve replacement. And yet half of those patients were not treated. And then on the right-hand side, you see patients with lower gradient aortic stenosis, so valve area under 1, but gradients under our typical thresholds, mean gradient 40, with either preserved or reduced EF, who had symptoms. And you can see that the majority of patients were not treated with aortic valve replacement. And again, there was a marked mortality cost associated with the lack of treatment. So this is providing rationale or warrant for why it's important to address this issue of undertreatment and to figure out how we might solve it. You can go to the next slide, please. And in an editorial that Angela and I wrote accompanying this paper, we tried to unpack some of the reasons for the current state that leads to undertreatment and some of the opportunities to bring system change in a way that might lead to more optimal treatment rates for patients with aortic stenosis. Next slide, please. So the AHA Target AS initiative was conceived in a partnership with Edwards, was formalized in 2019, and phase 1 took off. And that first phase included 15 sites that were part of a learning collaborative. Again, Vanderbilt was one of those, so I have experience from that learning phase. And there was also an effort to engage patients, increase awareness and education, understanding, also healthcare providers to make sure that there was adequate understanding of what the guidelines are in terms of the timing of valve replacement and indications for it, et cetera. But then also a very concerted focus on changing the system and leveraging what is a real strength of the AHA in terms of their Get With the Guidelines program, and to see what we could do in the field of aortic stenosis following that tried and true pathway. And then in 2022, this past fall, phase 2 was announced to continue this work and to expand it, which we are looking to do with incorporation of more sites. Next slide, please. So the goals of the program, or the goal of this initiative, is fairly straightforward. It's to identify, measure, and report on processes that occur from the initial echocardiographic diagnosis of aortic stenosis with the long-term goal of improving patient outcomes. That's our objective. Next slide, please. And you can see that to this point, quality in the management and care and treatment of patients with aortic stenosis has entirely focused on where it says current procedural registries. This is the STS registry and the TVT registry, which are procedural-based registries. So they deal with the time of valve replacement and onward and track whether or not quality of life improves or doesn't, whether there are other complications of the procedure, peri-procedurally or long-term. And those registries are very important. They can help ensure, particularly also through public reporting, quality in the performance of the procedure. But upstream of the procedure, there's been a huge gap. And that gap has led to what we went over in that first paper, namely very high percentages of patients who warrant valve replacement not getting treated with valve replacement. But our system has not been set up in a way that we even understand who those patients are, where they are, why they may not be getting to our multidisciplinary valve teams. And so the focus of this initiative is to shine a light on that period upstream of the valve replacement procedure to try to ensure quality and timely referral and treatment. Next slide, please. So here you can see the care pathway for a patient with aortic stenosis that includes treatment and monitoring at the end. But very importantly, it starts with awareness of the disease so that our antennae are up to detect it. And once it is detected and diagnosed, to engage in timely echocardiographic surveillance, and when appropriate, referral to a multidisciplinary team for consideration of treatment. Next slide, please. So in phase 1 of this initiative, we aimed to develop case report forms that could be utilized to gather information on patients over a longitudinal trajectory throughout their period of having moderate and severe aortic stenosis. We had 15 pilot sites that met on a quarterly basis in a learning collaborative to process and dialogue, what's happening. Are you able to identify these patients in your echocardiographic screening? Are there problems with the case report forms, confusion over definitions, et cetera? How is your site putting in echo alerts that other sites don't have? So there was a lot of that dialogue among those 15 hospitals. And this registry included the entry of data on 2,700 patients over the course of 8,000 patient encounters. So several of those patients had repeated encounters as they were followed longitudinally over time. Next slide, please. And phase 2 is aiming to build on this work of phase 1 and again engage patients to ensure understanding of the disease and awareness of it, and also to engage healthcare providers, ensuring that they understand the AHA-ACC valve guidelines regarding the management and referral and timely treatment of patients with aortic valve replacement. And then particular focus and a lot of the effort and energy is at the system level and trying to expand the number of sites who are involved from 15 up to 80 by the end of this second phase, which is ambitious, but a real desire so that this can be a broadly distributed quality improvement initiative. And as we go, as we've moved from phase 1 to phase 2, the CRFs, the case report forms, have been refined to clarify certain things, to try to make them as lean as possible. Some of the metrics have been refined, and we've engaged in a very thorough process of making sure that the data elements that are going to the registry are mapped very clearly to the metrics that will be a part of this quality assessment initiative. Next slide, please. So this is the scientific advisory group, robust group of leaders in the field of valvular heart disease. Clyde Yancey and Greg Fonro have been the co-chairs of this group in phase 1 and will continue in phase 2. And as we've moved into phase 2, this group has been expanded substantially. And for those in the valvular heart disease field, you will recognize many of these names and faces, representing interventional cardiologists, imaging cardiologists, and surgeons to bring together multiple perspectives on this initiative. Next slide, please. So these are our phase 2 measures. The prioritized primary metric you see at the top, and that is, again, trying to create a North Star, if you will, like patterned after, if you will, the what was done in the realm of ischemia, where there was a recognition that delays in revascularization were associated with worse outcomes and that there was heterogeneity from center to center. And so they implemented a door-to-balloon time that tried to align many stakeholders around a common quantitative goal. And so similarly, we're looking for a percentage of patients among those with a valve area less than 1 or a peak velocity greater than 4, the percentage of patients with a class 1 indication for AVR who received definitive treatment with valve replacement within 90 days of initial diagnosis. That is the thing that we're leaning most heavily into. And of course, there are exceptions for patients for whom that would be deemed futile, and that will not be counted against sites. That's all baked into the system and the way we assess the metrics. Additional measures include the percentage of patients for whom we can't figure out if they have a class 1 indication due to missing data. The percentage of patients with severe AS treated with a valve replacement who are evaluated by the multidisciplinary heart team. This is a class 1 indication in the guidelines, and so we're trying to encourage that and assess that. And then the percentage, now we're also looking at echocardiographic reports and performance and trying to make sure that echocardiographic reports are complete with the appropriate information needed to manage and make decisions on patients with aortic stenosis. And then ensuring in terms of patients who aren't yet needing valve replacement because they're earlier in the disease process, trying to make sure that those who have moderate aortic stenosis or severe are getting their echoes in a timely manner every 6 to 12 months for severe, or every 12 to 24 months for moderate. So these are many of the things that we're going to be looking for as phase 2 measures. Next slide, please. So this is a recent publication that came out last week, actually, and this summarizes the data from our phase 1 of our programs and lays out some of the objectives and next steps as we move into phase 2 of this program and seek to continue to refine it, improve it, and scale it. And so we're very excited about this initiative and the opportunity to make a very meaningful impact in the care of patients with aortic stenosis, with the ultimate goal of optimizing outcomes and ensuring that the patients who warrant valve replacement are getting in a timely manner. And this registry, this quality initiative, is enabling us for the first time really to shine a light on that period pre-valve replacement, upstream of the valve replacement procedure, and try to understand that period when many patients are lost. So hopefully that's a helpful overview from someone who's been involved in phase 1 and gives you a sense of where we'd like to go in phase 2. So with that, I'll hand it back to Kaylee. Thank you.
Thank you, Dr. Lindman, for that wonderful background and explanation of why this initiative is so important. As Dr. Lindman touched on, during phase 1, there were a few areas we gleaned insight. The first is identification of patients during with aortic stenosis. How do you identify all of your aortic stenosis patients? We found everyone had a different way of doing this, some being easier than others. Once identified, moving the patient through the journey to appropriate definitive treatment can be challenging. Do they have comorbidities that prevent them from receiving timely treatment? Once diagnosed, are all patients being referred up the chain, or do they fall through the cracks here? What happens after a severe diagnosis? Do they get scheduled for a multidisciplinary team visit in a timely manner? Lastly, that shared decision-making process. How is your institution handling multidisciplinary team meetings? Do some patients go straight through to CV surgeon or SAVR when TAVI should have been considered? Next slide. Some of the barriers to care we identified in these areas of insight are lack of surveillance tools while moving patients through the journey, limited abstraction resources. We know this is a hurdle for many, if not most, hospitals. Institutional buy-in, clinical recommendations in the ECHO report. And in phase 1, we saw that many hospitals don't have this piece in place. Time of MDT to AVR is not prioritized. While it was thought about, it was not necessarily measured or tracked. It's difficult or impossible to impact patients not in the system. SAVR patients are often not part of that multidisciplinary team process, which can be appropriate at times, but not in others. How to document and track patients that don't continue in the system for an unknown reason. Time of multidisciplinary team meeting may not always be the time of decision, and this varied widely from site to site. Today, our panelists are each going to discuss how they overcame the initial barrier identifying their aortic stenosis patients. We determined in phase 1 that while data input into the registry is a time consideration, finding patients and all of their relevant data is the hardest part. It's my pleasure to introduce Shauna Verberg, Manager, Clinical Registries at the Center for Cardiovascular Analytics, Research, and Data Science at Providence Heart Institute in Portland, Oregon.
Hi, everyone. It's my pleasure to be here. Gary, can you advance the slide, please? So I come to you today from Providence St. Vincent Medical Center in Portland, Oregon. We are a 523-bed teaching hospital in Portland. We're a large cardiac care provider doing about 350 TAVRs a year and over 1,000 cardiac surgeries a year. We are a regional referral center for valve services in the Northwest. And like Kaylee said in the introduction, my group is called CARDS, Center for Cardiovascular Analytics, Research, and Data Science. And within CARDS, which also houses our clinical trials and investigator-initiated research departments, I manage a registry team, which consists of nurse abstractors who support registries, cardiovascular registries of all kinds, of which the Aortic Stenosis Project is one. At our site, we use Qcentrix for data abstraction. So my role as registry site manager is sort of an oversight role. I communicate regularly with the abstraction team at Qcentrix, but no one in my group is directly responsible for abstraction. In my group, we have the role of data analyst, which, as you'll see later in my presentation, has been key to my success. Having someone with access to reports and Epic reports and other tools has been very important to my success. Okay, next slide, please. So we started out with this primary goal to develop best practices related to diagnosis, treatment, and follow-up of patients with moderate or greater degrees of aortic stenosis, much like you've already heard. We made the decision, the medical director of my CARDS team and the division chair of structural heart at my hospital made the group decision to join this initiative. We agreed with the mission of quantifying these quality measures related to moving this population through the trajectory. And we had participated in other American Heart Association registries, and we knew that it would be a worthwhile endeavor. So as far as our process goes, the first hurdle is identifying participants. And that was my main reservation to participating at first. When presented with this question of how to identify patients for this registry, I had no idea where to start. We had TAVR patients in TBT and we had SAVR patients in STS, but we also wanted to get to the people, most importantly, who weren't being treated, to identify barriers there. So we wanted to identify who wasn't being identified, which seemed like a tough task to me. I had resources. Gary Myers and the Target Aortic Stenosis group were very helpful. And I was part of the super user group of other sites going through this parallel process. So after extensive communication and sort of batting around ideas, I leveraged a contact I had in our echo department here at our hospital. And he, the supervisor of echo, had an Epic report that he used for a completely different purpose that he was able to share with me when I shared with the analyst group. And this is a list that could be refreshed at any time. And it just contained all the echo data of every patient who had an echo. So this is where we started. It had columns for severity and all of the measurements taken during an echo. And so we started there. I started out by trying to figure out myself who was moderate or severe based on the echo measurements. At the time, there weren't standards set by the AHA for this. And so there was some conflicting data. Not all measurements would be in agreement with level of severity. So that was tough. So what I did was I used the subjective quantification of stenosis, mild, moderate, severe, critical, that showed up on this report that was entered by the echo tech and verified by the reading physician. So that was how we identified our patients, the moderate and severe patients that way. And then in phase 1, we wanted to know if the patients were being treated medically or with intervention. So I leveraged the TBT data and the STS data to identify those patients who had had an intervention. And so I got to those groups, and then the list was sampled with the Joint Commission sampling procedure, which I'll talk about in a minute. The sampling was done by an analyst, and it requires writing a code. We use RStudio, which is a statistical software, to generate random numbers for individual patients from a random number function. So every case has the same chance of being selected. Now in phase 2, there are new sampling guidelines, which clearly identify who is moderate and who is severe. These parameters have been established. So I was able to categorize the patients much easier into moderate and severe categories. And it was interesting to do the 2 different methods over the 2 different phases, because I noticed when I used the newly established American Heart Association guidelines for what qualified as moderate and severe, there were a lot of lists that, a lot of patients who showed up on my list who were labeled mild. So I was making a much deeper cut into the patient population by using that new method. So abstraction is done using this data collection tool, which is powered by IQVIA, which some of you in the registry world may be very familiar with. So IQVIA is a very established, well-designed tool. The targeted aortic stenosis tool has become much more efficient based on feedback from users. In phase 1, all encounters had to be entered after initial enrollment. And in phase 2, there are clearer guidelines about what qualifies as an encounter and clearly defined endpoints to following patients. So like I mentioned, for Abstraction, we partner with Qcentrix, and I communicate regularly with the Qcentrix team lead on that. So the next stage in the process is data review, and this can be done internally or in conjunction with American Heart Association. It's very easy to go into IQVIA and run some reports and just take a look at your data, and you can identify opportunities, and also you can the validity of your data, if you're answering the questions correctly, if it all makes sense. So it's really nice to be able to do that data review on your own, or like I said, also in conjunction with American Heart Association. And then process improvement is the ultimate goal here. And based on the findings related to the measures and the measures reports that are available on IQVIA, you can run these projects. You can have data-driven projects and work with your quality team. The example of sites integrating clinical recommendations in the echo is a good example here. So work is occurring at the site and AHA levels around integrating this change at sites. So in conclusion, I would just say that now that the process has been established and refined, it's a minimal lift quarterly to get this list and support abstraction and data review. AHA has been very responsive to pilot sites' feedback about making the identification process and data collection workflow as smooth as possible. They recognize that patient identification methods are not the same at all sites, and they're comfortable with that. So I would just conclude by saying that participation in this initiative has been enlightening and interesting for my site. We've identified gaps in continuity of care that can easily be addressed. Thank you.
Thank you so much, Shauna, for sharing your path to success during phase 1. Next, I'd like to introduce Lucia Gordon, Advanced Practitioner Coordinator for Quality Data at Geisinger Medical Center in Danville, Pennsylvania.
Great, thank you. So good afternoon or evening for those here on the East Coast. Thank you for having me today. So I apologize for not being on camera. It just didn't work out with my setup, but that's okay. The slides are really what you need to see. So as Kaylee said, my name is Lucia Gordon. I'm a physician assistant at Geisinger Health System. Our health system has multiple hospitals across Northeast and Central Pennsylvania. And as you'll see on the next slide, I work at our largest campus, Geisinger Medical Center in rural Danville, Pennsylvania. This hospital is a level 1 trauma center with almost 600 beds. We perform an average of 550 open heart surgery cases annually, with about 100 of those aortic valve replacements plus or minus a CABG, but that does not include our aortic valve replacements for aneurysms or multi-valve replacements. We also perform about 175 TAVIs annually. I personally worked at Geisinger for 16 years, the first 10 as a clinical PA in cardiac surgery, and the past 6 in data and analysis. My main focal database is the STS, Society of Thoracic Surgeons, previously in adult and congenital, but now I strictly do congenital. And for the past 4 years, I've been involved in this Target Aortic Stenosis initiative with the AHA. Now, I was asked to present today on how we obtain our patient sampling in phase 1. Now, each year we calculated the patient load difference. So I'd like to go through how we obtain that patient load in each year. The next slide will show you 2020. So in 2020, which was the first year of the initiative, the paperwork was not completed until the end of the year. So we didn't get to start putting our baseline data in until January of 2021. And since we started entering data in 2021, we used 2020 as our resource on echo counts. And as you can see from the slide, the requirements were 20% of the moderate or severe aortic stenosis echoes, or a minimum of 60 patients, with half being procedure, so TAVI or SAVR, and half being medically managed. So obviously, to calculate the 20%, I first had to determine how many echoes were moderate or severe. I contacted our Echo Lab IT lead, and she was able to quickly pull those echoes via the echo program Accelera. We had a total of 472 echoes. Now, during the first year, I was under the assumption the patients needed to be seen in the multidisciplinary valve clinic to be entered into the database. So I went through every patient on the clinic list for every month to find the procedure patients and the medically managed patients. Once these lists were created, I entered all the data manually for those patients. Now, I did this work during the first quarter of 2021 and entered 72 patients. Now, if you're quick with math, you'll notice that this was not the required 20%, but that is what I was able to enter manually in that short time frame. Next slide, please. In the 2021 data and sampling, during the second quarter of 2021, I was working with our IT department on how to minimize my workload for this project. I was blessed, truly blessed, with a senior business intelligence analyst who was able to create and integrate an internal electronic abstraction program using unified data architecture. Now, this is a whole other presentation that I won't go in today, but I just like to brag about her just because she was a godsend. So the requirements for 2021 sampling were a straight 20% of our moderate or severe aortic stenosis echoes. Now, this analyst, her name is Amy, used Accelera along with Lumidex to determine our patient load, which we once again used the 2020 echoes. So with these programs, she was able to dig deeper and determine which of these patients had both the required echo and an office or admission encounter linked to aortic stenosis. So that helped us determine our load. And then it took until the summer of 2021 to get this program all set up and finally pulling and entering accurate data. Now, she used Accelera, Clarity, and Epic to abstract the data. We initially pulled 70 patients for quarter one, and that was close to our 20% requirement. Now, I do apologize, I do not remember our exact number for 20% and how many patients were of the echoes, but I know that was close. Now, at some point, both of us thought we heard that we were supposed to be entering that 20% number for each quarter. Then we recognized later at the end of the year that we were mistaken and we entered way more patients than was required. And with that said, we entered 200 patients for 2021. Now, this was not a problem on our end, since the program that she created took the abstraction time from 2 hours per patient down to 20 minutes. Next slide, please. Now, using the same abstraction program, we move into 2022. So the sampling requirements for 2022 changed quite a bit. We were still required to enter 20% for which we were to pull from the moderate and severe echoes from quarter one. So remember, in 2020 and 2021, we used the whole prior year to determine our echoes. Now this, we're just using the first quarter of 2022 and determining our 20% from those patients. This was our required number to be entered for each quarter, and I'll explain that here in a second. So ours was 40 patients. So if any patient graduated during that quarter, we had to replace them with a new patient, a total of 40 patients entered for that quarter. And as you can see on the slide, the graduation criteria was death, 30 days past TAVI, 90 days past SAVR, or if they were placed in palliative care. Now, using Accelera and Lumidex, Amy determined the initial patient load. Then again, using Accelera, Clarity, and Epic, she would abstract and enter most of the data. So we ended up having a total of 56 patients for 2022, which means only 16 patients graduated. So throughout last year, hearing the other sites speak about their graduation percentage, and so far for this year entering the 2023 data, I'm pretty sure our graduation percentage is much lower than the national average and our average across the board at Geisinger. Now, these patients were chosen at random, but they leaned more on the medically managed and the moderate aortic stenosis side. So that concludes how here at Geisinger we obtained our patient load for phase one. The first 3 years, we've learned so much on both Geisinger side and on the AHA project side. We were able to really work on the database and determine the data points which were relevant, figure out how to accurately identify the patients that needed to be entered into the database and how to get those patients, and started the process of what our hospitals look like compared to others. We're learning more and more each quarter when we receive our updated data reports. So thank you to all those who joined today's webinar, and I hope that our presentation today helps you decide to join the initiative, or if you've already joined, I hope it helps. Thank you.
Thank you so much, Lucia, for sharing how you were able to find your initial patient population and make the process work for you at Geisinger. Next, I'd like to introduce Carrie Davis, MSN FNP BC Director, Center for Cardiovascular Care, Cardiac Surgery, Comprehensive Aortic and Structural Heart at WellStar Center for Cardiovascular Care in Marietta, Georgia.
Thank you, Kaylee. Can you hear me?
Can.
All right, awesome. So thank you for the introduction, and hello to everyone who's joined the webinar today. Like Kaylee said, I am a nurse practitioner, but I function primarily in the administrative role for cardiac surgery and structural heart at WellStar. Today I'm going to give a high-level overview of how we identified our aortic stenosis patient population, our sampling plan, and then how we approached our data abstraction and some key lessons that we learned from that. Since the project started a few years ago, like others have said, this has been a very insightful and educational group that has been looking at this patient population, and just very excited to extend this into phase 2 so that we can continue to learn more. Next slide. So WellStar is one of the largest health systems in Georgia. We're one of 4 health systems in the Atlanta metro area. So to say the least, we reside in a very highly competitive market. It is a 9-hospital system, and the majority of our high-end surgical procedures are performed at Kennestone Regional Medical Center in Marietta, Georgia. There we do all of our cardiac surgery and structural cases. And we average about 800 to 850 cardiac surgeries and 200 to 250 TAVRs on a yearly basis. Next slide. So when we first started out looking at this project back in 2019, like others, we kind of had to take a pause and say, how is the best way to approach identifying this patient population? And, you know, it came down to how do we leverage our EMR system. So at WellStar, we utilize Epic, and so all of our echo reporting is done inside of Epic. So that helped kind of ease the burden with that, because we were able to pull data directly from discrete data fields built in Epic into a registry report. So once we kind of decided that may be the first approach, I submitted a registry report request to our Epic IT team and was assigned an IT data analyst who I worked very closely with. We compiled a list of metrics for inclusion in the report, and these metrics are on the right side of the screen, and of course included patient first and last name, the MRN, date the echo was performed, the aortic stenosis severity grading, and for the purpose of this project, I only had the report pull moderate and severe. I intentionally excluded trace and mild. We also pulled the LVEF, peak velocity, aortic valve area, as well as the mean and peak aortic gradients. With doing that, it gave us a lot of useful data, and we then had the report built and put into production, and the data was exported into an Excel so that we could pivot the data as we needed to meet the needs of sampling our patient population. Of course, there were additional metrics we could have included in there, but we felt like this was good enough to start. And I think as the project went along, we learned that, you know, this was pretty inclusive of everything that we should have included. I would like to point out that for phase 2 of the project, if you're considering doing a registry report, you certainly want to make sure, of course, that you have the demographics and the aortic severity grading and EF, but peak velocity and aortic valve area are some of the metrics that are kind of absolutely required in order to for inclusion in the tool. So just make sure that you include both of those. Once we had the report up and going, we then spent a great deal of time validating the report, making sure that the data was accurate, it was pulling the patients. We would look at our TAVR and SAVR cases and make sure that those patients were pulled in appropriately, just because we wanted to have that, check and balance to make sure that everything was as it should be. Next slide. So when it came to the sampling plan, and I won't go into a lot of this because the other panelists have mentioned that, but I did run the report for the first quarter in 2020 to determine our base load for those patients with moderate and severe AS, and then took a 20% sampling of that. Our base load was about, it averaged, in the beginning of the project, it averaged about 95 per quarter. And then towards the end, towards 2022, we had about 106 patients as our base load. Each subsequent month that I ran the report, depending on how many patients had actually met the criteria to be graduated, then I would take that report and then evenly sample in order to get my list back up to the base load number. With phase 2, the sampling plan is a little bit different. It's going to be 15% for severe AS and then 5% for moderate AS. Next slide. The next step was data abstraction. Unfortunately, at WellStar, our internal cardiac data abstraction team that submits data to TVT and STS really did not have the bandwidth to take on this, but we really were committed to understanding this disease state and how we could be partners with AHA in this work. So we enlisted the help of a data abstraction third-party vendor service known as Qcentrix. So they did all of our data entry into the AHA AS tool for us. What we did is simply provided them a sample list onto a SharePoint site for their abstractors to utilize. After the first quarter, we went back and did some quality review on the patients that they abstracted on our behalf, just to make sure that they were capturing everything, because as you know, no one knows your EMR better than you do. So we then identified some opportunities, provided some education to the Qcentrix abstraction team on where they could find this data in our EMR. And that proved to be very beneficial and worthwhile for us. Additionally, one of the things that we did for each subsequent quarter was that before providing the list to them, I would actually review all of the patients in the base load to identify if they had been seen by cardiology, a structural cardiologist, or cardiac surgeon. And I would point that out in the list that I provided to them, who was seen or who the patient saw in terms of the provider type, as well as the date that the patient was seen by that provider. And that was mainly just done to make sure that there weren't patients inadvertently excluded from having their data accurately entered in the tool. So with that, I hope that provides a high-level overview of what you may expect if you decide to participate in phase 2 of the project. I would certainly like to thank AHA for their commitment to identifying and providing guidelines for providers as they care for patients like aortic stenosis. And I think we all can agree, based on the discussion today, that many of these patients are underdiagnosed or undermanaged, and anything that we can do to elevate that work is important. And I think that's exactly what this project is doing for us. And so I would strongly encourage you to consider being a participant. So thank you for your time, and thank you for letting me speak today.
Thank you so much, Carrie, for sharing your experiences that helped to make you successful in phase 1. Next, I'd like to turn it over to my colleague, Erin Leash, who will share information on the next steps of getting involved in target aortic stenosis.
All right, thanks, Kaylee. So we've already heard a little bit about some information in regards to the phase 2 part of Target AS. And so I'll give kind of a recap. We'll get a little more granular in what participation will look like. So as part of phase 2, of course, we'll continue to abstract moderate and severe AS patients using the sampling plan that we have currently in place. And of course, we're going to leverage learning collaborative model, which includes some of the activities that are listed on the slide. And those will include all site meetings, which are a great way for the sites to come together, really to collaborate on barriers and challenges and successes, and maybe some solutions to some of those barriers that may or may not work for your site, but might give you some ideas on how to overcome some of the barriers that you might be experiencing. We also will hold super user calls. It's a great way to leverage, again, the opportunity to meet with our group and talk a little bit about really finding solutions and maybe some model sharing to help figure out how to get around some of the barriers or overcome them. We'll also have some one-on-one meetings with the program and registry teams, clinician roundtable calls. There's lots of opportunities for the ECHO groups and research groups to meet as part of the learning collaborative. In addition to that, and I think Dr. Lindman touched on some of this, there's some model sharing and national education opportunities through podcast series being developed, some webinars, and other ideas where we can get information out to the groups. Next slide, please. So really the big question is what opportunities are there to participate, and how can you participate, or your organization? So currently, there's really 2 levels. So the first one really is we're seeking a limited number of additional hospitals to join that core site group of the 15 pilot sites. And part of that, again, you'll participate in learning collaborative with those core sites. And that will help us shape the program by providing the insight and feedback, again, sharing barriers, seeking out solutions on a national scale, what works, what doesn't work, and then participating in research and scientific presentations, whether it be a regional or a national level. Again, you'll continue to abstract and enter data into the registry for those moderate and severe AS patients as identified by ECHO, including the demographic information and the patient's relevant visit and or procedure. And again, we'll leverage the sampling strategy that has been developed. Also, we ask that they implement a quality program within their hospital so that they're using what is learned from the data and learning collaborative activities and providing that feedback to us to see how things are going for them. Participation in Target AS is currently offered at no cost, which is fantastic. The participating sites will be eligible for a participation incentive for the 3 years of this phase of the initiative. This is primarily intended to offset the cost of a data abstraction. However, the site can use those funds at their discretion. Also, we'll be working on and be a part of national recognition that will be based on defined achievement measures as we develop that program. And so next slide, please. Okay, the other opportunity which is coming up down the pipeline is really once the core sites have been identified and we filled those opportunities, we want to bring on another 55 additional sites to join the registry and quality program. Again, they will have some of the similar abstraction and data requirements for their moderate and severe AS patients. Again, leveraging our sampling tool and strategy that we have in place. And then again, the tool will be offered at no cost to them. And we will also have a participation incentive that will be available during the 3 years of the initiative. And again, they have the same, they can use those funding dollars at the discretion of the site. So national recognition, again, they'll be eligible for that based on the defined achievement measures. The one big difference is the sites will not participate in the learning collaborative activities. So there are some ways that you can come on board depending on the level of involvement that your organization would like to provide or be a part of. So, and next slide, sir. So for more information or to get a little bit more granular information from us, you can reach out to us, the Target Aortic Stenosis site at www.heart.org/targetas, and you can reach out to us there. So with that, I will hand it back to Kaylee. And Kaylee, are you there?
Aaron, I'll jump in.
Very good.
Yeah, I wanted to see, just as a reminder, if there are any questions anyone has, of course, you can reach out to us through the website. We have a lot more information on the website, including a lot of information about phase 1. And of course, you can reach out to us through the website. If there are any questions today, you can go into the question pane, and we'll stick around for a few minutes here to see if there are any questions, and we will answer those questions as they come in. Currently don't have any questions that have been submitted, but if there are any questions, now is your opportunity to jump in that question pane and go ahead and ask them. So we'll wait just a minute here and see if there are any questions.
Thanks, Gary. Can you hear me?
Yep, we got you now, Kaylee.
Okay, thank you. Do not see any questions. After today's webinar, you will receive a follow-up email with a survey on the presentation. We'd appreciate it if you would complete that and provide your feedback. In the email, you'll also receive a link to view the recording of today's presentation. On behalf of the American Heart Association and the Target Aortic Stenosis Initiative, thank you for joining us and have a great day. This concludes today's presentation.